So to briefly summarize the steps of the procedure, what we do is put intraoperative EEG electrodes on the scalp, and then general endotracheal anesthesia is induced, and we have a baseline EEG. Thereafter, the patient is induced with general anesthesia. The roll is placed under his shoulder, and his head is placed in a donut and rotated approximately 15 degrees to the contralateral side of the surgery. We then make an oblique incision along the medial border of the sternocleidomastoid muscle, taking the dissection down to the common facial vein, which is taken by a suture ligature. We then deepen the dissection to identify the common carotid artery, which is isolated with an umbilical tape, the external carotid artery isolated with an umbilical tape, and the superior thyroid artery isolated with a vessel loop, and finally the internal carotid artery, and in so doing identifying the hypoglossal nerve, which in this case was at the superior aspect of the dissection. Once we have adequate exposure and hemostasis, Rommel tourniquets are placed on the common and internal carotid vessel loops, and then the patient is given 5,000 units of heparin. After 3 minutes, the first bulldog clamp is placed on the internal carotid artery to isolate circulation and to prevent any distal emboli from flying up into the brain. And then simultaneously, a DeBakey clamp is placed across the common carotid artery and another bulldog clamp across the external carotid artery. An arteriotomy is performed with an 11-blade knife initially in the common carotid artery and then extended with pot scissors into the internal carotid artery past the plaque. We then do a circumferential dissection using a number 4 Penfield dissector around the plaque in the common carotid artery, placing a right angle dissector under the plaque and cutting the plaque sharply with a 15-blade knife. We then evert the plaque from the remaining portion of the common carotid artery, as well as the external carotid artery, and then feather it out of the internal carotid artery. In this case, there was still a little free fragment of plaque, which required a tacking suture using a double-arm 7/0 proline, and that held the plaque down. We then close the arteriotomy using a double-arm 6/0 proline, going from internal to external and running it from distal to proximal, and a second double-arm 6/0 proline, running it from proximal to distal. Prior to complete closure, we irrigate with heparinized saline and also allow for retrograde and anterograde bleeding to make sure there are no other free fragments, and then close the arteriotomy. I then allow for several pulsations from the internal carotid artery, replacing the bulldog clamp, and then open the common and external carotid arteries simultaneously, allowing 10 pulsations, and then opening the internal carotid artery. We then assess flow with a Doppler, and at that point we make sure that the entire operation is hemostatically dry. If there were a leak along the arteriotomy, we would close it with a figure of 8 7/0 proline. In this case, that was not needed. Once hemostasis is achieved, the wound is closed using 3 ovicral in the platysma and a 4 ovicral subcuticular stitch.